of nystagmus or dancing eyes as it is commonly called. This is basically a sign, not a disease process itself. It is a constant repetitive cycle, repetitive movements of the eye, which is basically a problem between the labyrinth of the brainstem and which results in these abnormal movements. So basically, nystagmus has got a slow phase, which is very important, and a fast corrective phase, which we are attracted to it. So slow movement systems, as you all know, is visual fixation, vestibular system, and neural integrators, pursuit systems. So these are the common terms which are used when we are dealing with the case of dancing eyes or nystagmus. Either it is pendular or a jerk nystagmus, depending upon the type of fast movements towards which side, and whether it is a horizontal, vertical, torsional, or circular. So amplitude is how far does the eye move, and frequency how rapidly it moves. So it can be infantile nystagmus or acquired nystagmus. Induced nystagmus is another variety which we can create, which we all know. So this is optokinetic nystagmus, which we can see at the extremes of gaze and when it is following the drum. And physiological nystagmus are normal variants of motor function. So this is by taking the ocular movements far too laterally and trying to fixate. So this can be an optokinetic nystagmus. It is multidirectional and it is in response to a moving object, and slow phase is ipsilateral to the vertical stimuli. So vertical vestibular ocular reflex, we all know when injecting, this is because of the semicircular canals. If it is a horizontal canal, you will get a type of nystagmus, caloric nystagmus, which we call. And if the caloric stimulus is given in both the eyes, it will be an upward nystagmus, because the vertical semicircular canals are also affected by it. So how to approach? So there is nothing to fear and nothing to get confused about the dealing with the case of nystagmus. You just have to ask age of onset, whether from when it is present, whether it is acute or it has been present for a long time, whether it is present from birth, and history, what the patient says, whether about the history of oscillopsia, and that shows that it could be an acquired nystagmus. So visual acuities are very important examination point which we should take. Sometimes poor vision, poor maculation, or macular disorders can result uh, in the onset of nystagmus. Macular disorders, albinism, all these can result in nystagmus. So, a study of the features of nystagmus in all cardinal positions of gaze will tell you which movement, during which movement or which direction of the movement the nystagmus is accentuated. And also we should observe the presence or absence of the head oscillations, head position, and we should also try to note where is the null point for this nystagmus. Null point is where there is a minimal amount of nystagmoid movements. So congenital nystagmus can be because of the sensory defects, as I already mentioned, and it can be associated with squint. Usually, these things congenital are from birth, and sometimes autosomal dominant inheritance pattern can be seen in these patients. Acquired nystagmus can be sudden. Acquired nystagmus can be due to drug toxicity, which is common, particularly lithium can be common precipitating drug, which is commonly given nowadays for many psychiatric disturbances. Multiple sclerosis, a small nystagmus movements can give you an alert regarding the onset of multiple sclerosis. Same thing can be observed in certain cases of brain tumor and head injury. So drug toxicity should never be forgotten. So spontaneous nystagmus, It can be a downbeat nystagmus or an upbeat nystagmus or torsional dystagmus. The importance is these type of pathological nystagmus usually indicate type of where is the location of the lesion. So usually vertical nystagmus is located because of posterior in the posterior fossa lesions, medication side effects, and vitamin A deficiencies. So you can see the downbeat nystagmus. This is due to the herniation of the tonsils. Here you can see the tonsil which is herniated into the foramen magnum, and that results in the downbeat nystagmus. An upbeat nystagmus is usually lesions in the brainstem with other features of brainstem lesion will also be there. Um, so this will give you a clue about the location of the lesion. Seesaw nystagmus, again chiasmal lesions can precipitate this type of nystagmus. Torsional nystagmus, then retracted nystagmus due to dorsal brainstem syndrome, also to be noted, can be a indication. So, all these things what we talked about nystagmus is basically a slow phase movement with a corrective fast phase. Now, when we come to fast phase, which is again very rare, this can be due to ocular bobbing or opsoclonus and flutter, which are all very rare but very difficult to not very difficult to diagnose, because you will always note that there is a compensatory head movement along with it. In nystagmus you don't find a compensatory head movement, but all these there will be a compensatory head movement for that. I offer my special thanks to my mentor and my teacher, Professor Vijayaraghavan. uh, thank you so much for your listening. Thank you.
Thank you, sir. Full screen. Full screen. Uh, Good morning, everyone. I'll be talking upon approach to common optic neuropathies. Optic neuropathy means there is degeneration of the optic nerve, which can be hereditary or which can be acquired. And this degeneration results in changes in the optic nerve head and the surrounding RNFL, mostly as a result of direct or indirect damage to the ganglion cells and its axons. So this is a list of inherited and acquired optic neuropathies. The acquired will be optic neuritis, which could be idiopathic, associated with MS or isolated, associated with NMOSD or a cryon or post-infectious, post-viral. It could be ischemic, it could be due to toxic or nutritional causes, due to inflammatory disorders or connective tissue disorders. It's a whole list, but it's important to know the differentials if we want to investigate a case of optic neuropathy. So I think history is this is one of those subspecialties where history is most important. We get a lot of clues from the history, and this is where we start when we're investing one case. So a rapid onset would mean a demyelinating, inflammatory, ischemic, or a traumatic cause. A gradual course would mean a compressive, toxic, nutritional, or a hereditary cause. Then we have to be very specific about other neurological symptoms like ataxia, limb weakness, paresthesia could mean a demyelinating lesion. Painful ocular movements could be seen in idiopathic optic neuritis or MS. Transient diplopia may be due to a compressive optic neuropathy. Jaw claudication, temporal pain might be seen in a giant cell arteritis. So history of medications is very important. ATT, we know ethambutol, but INH and now multi-drug resistant drug linozolid is being increasingly used with optic neuropathy. We have to take this history. Antimalarials, chemotherapeutic agents. We have to keep an eye on the latest fever on the block, COVID, chikungunya, dengue. All of these can cause optic neuropathies. Any history of vaccination. Any addiction, this can lead to secondary nutritional optic neuropathy, or as in alcohol, it can lead to toxic optic neuropathy also. Medical history of hypertension, diabetes for a non-arthritic ischemic optic neuropathy, a recurrent vision loss could be a cryon. A hereditary optic neuropathy could be a dominant optic atrophy or a Leber's hereditary optic neuropathy. Examination would mean a lot of things, including color vision, pupillary reaction, which is important, and then the investigations like the visual field testing, the VP, the OCT, and the neuroimaging of the brain and orbit. The classical clinical signs of optic neuropathy are visual field defect, dyschromatopsia, and an abnormal pupillary response. The disc may be normal, pale, or edematous. Slit lamp microscopy is important to rule out the differentials. Evidence of uveitis, post-uveitis has to be seen. A pale optic disc would indicate a long-standing optic neuropathy. There can be a sequelae of an ischemic optic neuropathy, a sectoral pallor, signs of optic atrophy in the form of when seen in red free light, when we see slit-like or wedge-like defects in the peripapillary nerve fiber layer. So a lot of clues can be got from just analyzing the disc also. If you see the Leber's hereditary optic neuropathy, if we see this circumpapillary telangiectatic vessels, this disc became pale after a month. Another thing which we should note is whether we are seeing a typical optic neuritis or atypical optic neuritis. And we can see the difference is more disc edema, hemorrhages, exudates in the atypical optic neuropathy. They might be associated inflammation. In the typical ON, there'll be no inflammation. It will probably resolve by itself. It is a better prognosis. Atypical ON can be seen in NMOSD, MOG antibody disease, or a lymphoproliferative disease, or a vasculitis, or collagen vascular disease. Suffice to say that it has to be investigated even further. Neuroretinitis is mostly infectious, where we see a disc edema with a macular star. Drug toxicity can have a symmetrical kind of a disc edema, as here. Sector disc edema is seen in a non-arthritic ischemic optic neuropathy, pallid disc edema in arthritic ischemic optic neuropathy, a temporal pallor in any nutritional optic neuropathy. If our provisional diagnosis could be idiopathic optic neuritis or infectious, parainfectious, or it could be due to demyelinating lesions. Now, these are the demyelinating lesions which can lead to optic neuropathy, multiple sclerosis, neuromyelitis optica, or a MOG antibody disease. It's important to differentiate between the three with the help of biomarkers like the anti-aquaporin 4 antibody and the myelin oligodendrocyte antibody, because the treatment management, the prognosis and the management differs. Now, this is a case of a typical optic neuritis, recovered in 1 month. We saw disc edema in one eye, the other eye was also affected. This is also seen in the VP. There's a prolonged P100 latency. And this MRI is not of this patient, but if we see something like this, Dawson's fingers, demyelinating lesions in the white matter, this points towards MS-related optic neuritis and is to be treated as such. This is a bilateral atypical recurrent optic neuritis, which was seen in a young girl. And at that time, we didn't investigate for NMO. But later on, she developed transverse myelitis, and the MRI spine showed a long, extensive transverse myelitis lesion, which pointed towards NMOSD. And the anti-aquaporin 4 was positive, and she was diagnosed as NMOSD. So NMO will be characterized by severe optic neuritis, transverse myelitis, area posterior syndrome, brainstem lesions. Some subtypes sort of vomiting might be accompanying this. This is again a case of a MOG optic neuropathy, young female, atypical optic neuritis. And the MRI showed an anterior optic nerve and the sheath involvement. MOG was positive. She was given IVMP and put on long-term azathioprine. She still retains after 2 years a vision of 69612, though the disc has become pale. So features of a MOG optic neuropathy would be, so we suspect this when we have recurrent optic neuritis, mostly there'll be disc edema, pain because the optic nerve sheath is also involved. This has a better visual prognosis than NMOSD, but worse than MS-related optic neuritis. Now, why it's important that we differentiate between the three? Because as we can see, acute attacks of NMOSD can be treated with IVMP and might need PLEX, a plasma exchange, and maintenance therapy with rituximab or azathioprine mycophenolate. But if we are thinking in terms of MS optic neuritis, apart from what we have learned in the ONTT, as we have to give IVMP, but we might also be needing to give disease-modifying agents so that recurrence and the disability is lessened. And this drug, these disease-modifying agents, are of little use in NMOSD and MOG antibody disease. So in our country, we can have, or anywhere, we have a lot of infections, and we can have post-infectious optic neuritis. We can see a papillitis, or we can see a retrobulbar neuritis, but we can also see a neuroretinitis. Neuroretinitis is mostly infectious. And it's important to find out the cause of the optic neuritis, because the treatment would also entail treating the infection apart from the inflammation part of it. Now, this is a patient of a dengue optic neuropathy, which I saw last year when dengue was everywhere. And the patient came with optic symptoms of optic neuritis, the whole lot. And I just asked about history of fever. And 3 weeks back, the patient had fever for only 1 day. only one day, and I got him tested for dengue. It was positive, and this was diagnosed as dengue optic neuropathy. And subsequently, 15 patients, much more than foveolitis I saw in the last dengue epidemic sort of thing, which happened at my state. Optic disc tuberculosis is another infection. It's not very common, but seeing that we are a tuberculosis endemic country, we should keep this in mind. Also, because if we want to give IVMP, we want to see MON2s and we want to rule out tuberculosis, another reason. COVID-19 is coming in waves, and we should take history of COVID-19 also if we see a patient with vision loss. And this is usually in the form, because of the hypercoagulable state which is seen here, it's usually in the form of a non-arthritic ischemic optic neuropathy, and we might see altitudinal field effect. And this is a post-vaccine optic neuritis which is seen. So all this history is very important because it tells us the cause and we can manage these patients better. In a toxic nutritional optic neuropathy, mostly it can be caused by ethambutol, amiodarone, methanol, ethanol, or tobacco. Now, this is very difficult to get RAPD because it is symmetrical involvement of both the discs, and we get central or centrocecal scotomas, papillomacular bundles are involved, and there's a temporal pallor. Is the time done? Over? Oh, I'll just hurry up. So evaluation would mean, of course, vitamin B12, folate, and a peripheral blood smear to rule out the cause. History has to be taken about any malabsorption to rule out the cause of the nutritional deficiency, and it has to be treated accordingly. This is a patient with temporal pallor and a central and centrocecal scotomas, which is seen in these patients. This is again a patient of a methyl alcohol optic neuropathy. In this, the history is difficult to take. The patient will not admit to taking spurious liquor. And this is also important. This field shows a generalized depression of the field. And because the whole treatment modality changes if you have diagnosed a patient with a methyl alcohol optic neuropathy. And this is a kind of disc edema and the RNFL swelling that you see very typical in methyl alcohol poisoning. Non-arthritic ischemic optic neuropathy is also very common. As I said before, we see a sector disc edema. In AION, there's jaw claudication, headaches can be seen. And temporal artery biopsy is done to further manage these patients. And that is, in AION, one thing which I forgot is that the other eye is very important to see because you might see a disc at risk. And if you have doubts about the disc edema, the other eye will sort of confirm the diagnosis if it's a congested disc or a disc at risk. And this is a altitudinal field effect when you see there. This is the disc of a NAION, and we can see the sector disc edema, and below is that of AION. We have to investigate with ESR, C-reactive protein, and test for hypercoagulable state if the patient is under 50. Traumatic optic neuropathy, we see a lot of these cases. It can be indirect or a direct injury. But as these studies show, the verdict is still out on whether we are going to do optic nerve decompression surgery, we're going to give steroid, we're just going to leave like them. The best is to treat these cases on a case-by-case basis. To conclude, optic neuropathy can be caused by multiple causes. Careful clinical evaluation is essential to diagnose these cases. We have to recognize these entities so that we can manage them and prognosticate better. And additional tests like visual field testing, neuroimaging are very useful in the clinical evaluation. Thank you.
Thank you, doctor. Now I request Dr. Varshini Shankar to do spotlight on pediatric neuro-ophthalmology. Not there. So we will go to the next one. Dr. Pooja Hingarorani to talk on Bank tricky tract, the optic nerve.
So Tilly is connecting. I just wanted to tell you why I named it this. It's a tricky tract because when we always teach our students, we tell them, oh, it's not a nerve, it's a tract. Because of we usually associate nerve with something that is in the peripheral nervous system, from the sensory receptor to the spinal cord is the nerve. Then from the spinal cord to the lower brain is the tract. That's a second order neuron. And from the lower brain to the higher brain is a third order neuron. And that's the reason, as we all know, that, is it seen? It's not. That's the reason, as we all know, the first order neuron is the bipolar cell. Yeah. So this will be a case-based course, a 7-minute course. And so as we know, this first order neuron is the bipolar cell, which is, and the first synapse is the outer plexiform layer. The second synapse is the between the bipolar cell first order neuron and the second order neuron, which is the ganglion cell, which is in the inner plexiform layer. And the third synapse is in the lateral geniculate body, wherein the third order neuron starts. So actually, if we go to see what we are dealing with and what we call the tract, or what we call the optic nerve, is actually a tract, and it extends right from the retina, the pre-papillary part, the papillary part, and the post-papillary part. It's all the same axon. It's not synapsed, right from the retina, the nerve, the optic head, and the up till the LGP. So I'm going to discuss cases on the retina, on the optic nerve, and on the and behind the optic nerve. So these are all diagnostic dilemmas. So there's a 12-year-old male child. Madam has already covered a few, but they're all not typical cases, and that's why they're dilemmas and they're tricky. So 12-year-old male child brought to the emergency, fever, headache, weakness and inability to walk with urinary retention, very recent, and loss of vision. So I would just like to stress, and if any take-home messages, anything related to the optic nerve and beyond, it should be headache or loss of vision, or at least either. Usually both, but sometimes either. So he came to the emergency because these cases usually come to the emergency, but it's a male child. So otherwise, there was nothing great, just no other history, little bit of pallor, systemic was normal. CNS, yeah, lower limb had a little low power, and there were no ankle and knee jerks. So again, we will think of something involving the optic nerve and something that's going on lower down, so something like transverse myelitis. So this is something where we expected, okay, so the vision was PL plus minus, the child was unable to give it, RAPD was there, a small esotropia, not so significant. This is what we saw. So there is a significant edema in the left eye, and that is confirmed by this huge peak here. And if you can see here, the right eye looks normal, but the VEP shows that the latency is raised. So here we have something that's involving possibly both eyes and the spinal cord. We had to go ahead with an MRI. So here it is, the T2 weighted images. There is signal intensities are raised, and in the post contrast, there is a take up, and so this confirms the optic neuritis. There is a longitudinally extensive involvement of the spinal cord, and longitudinally extensive just means that more than 3 vertebrae are involved, across more than 3 vertebrae, and there is an enhancement and enlargement. And here across the T2 vertebra, we see there is an uptake, and this just means that here the channel, the aquaporin this is the nerve, there's the myelin sheath. So the myelin sheath itself has the MOG, or the myelin oligodendrocyte glycoprotein, which can have an antibody, or the aquaporin, where the blood-brain barrier is situated. So either of these can have antibodies. So if there's an aquaporin antibody, this is how the damage occurs. And if there's an MOG antibody, this is how that damage occurs, and the myelin is lost. So that's why these neuromyelitis optica was our clinical diagnosis, because these are the criteria. So we went ahead for both the antibodies, both were negative. Both were negative. So we went ahead for the criteria, which says if the aquaporin is negative, does the child, does the patient, fulfill these criteria? He fulfilled all of them. And even MOG was negative. So we started on IVMP with the pediatrics department, obviously. There was some benefit. From no PL or plus minus PL came to 2/60, and there was some neurological improvement. So as I showed you in these diagrams, there's a lot of IgG all around. So what they did was they went ahead and gave IV immunoglobulin and prednisolone, and the child came to 6/6. Now and they discharged the child walking. So the child had weakness. He went walking. He went 6/6. He went on a mycophenolate. This was the final picture. There's some pallor, yes. And yeah, there are some RNFL zones which are thinned out. So what was critical here was usually it's the female sex that's involved. Look at the age that should be involved, 40 to 60. It's associated with other diseases. The IgG helped us to, give the antibody IV that helped. And here it says poor recovery, but luckily for this child, male, 12-year-old, recovered fully. So not a classical case. There's another case, 47-year-old male. Diminution of vision only in right eye, 2 days, just a 2-day history. What happened? What happened? Look at this. What is this? What would you think of? So this is how the picture was, huge disc, optic disc, malignant hypertension. So we referred to medicine, patient was treated, came back with 6/6, resolved somewhat. You can see the succinate maculopathy coming up, a few flame-shaped hemorrhages here and there. This was a second visit, BP better and well controlled. Yeah, but he's going into some atrophy here. And this is almost like a secondary optic atrophy settling in. And yeah, so he didn't come to 6/6, he came to 6/12. And it's not a very good post-neuritic picture. There's another patient, 33-year-old, gradual diminution of vision since 1 month, but nausea and vomiting. 6/12, both eyes, frank papilledema. Now, this is quite classical. I thought, like, can't be all atypical cases. Yeah, so grade 4. And CP angle tumor diagnosed as acoustic neuroma. Another patient, 27-year-old, headache since 4 to 6 years, 6/6. So here there's no loss of vision, but there's a headache. As I told you, it could be headache or loss of vision or both or either, mostly. So, but there was some reduced hearing. So look at this. There's no papilledema either, right? But I would show you these. There are some cotton wool spots. There is some hemorrhage here near the disc. And look at this, in the right eye, again some hemorrhage. There is cotton wool spots, AV crossing changes, hemorrhages. So it's a grade 3 hypertensive retinopathy. So why would a 26-year-old, 27-year-old have a hypertensive retinopathy and a long-standing one at that? So disc appears okay. So what? So we did a medicine referral. It was hypertensive, concentric LV atrophy, hypertrophy. But then there's something in this disc which doesn't feel right. And there's that headache. So we did an MRI. Just look at these ventricles. So it is a communicated hydrocephalus. This is a T2 weighted. You can see patient was sent to neurology, acetazolamide was given. So there was another one, second month, first trimester of surgery. Yeah, first trimester of pregnancy. Left eye, 6/18. Nothing really, no? Can you see anything? No. But there is a bulge here. Just above the disc, there is a small bulge. Unfortunately, I can't show you a 3D image. And there's that bulge, which is seen. This was done outside, not at our center, the tests. Vision further dropped to 6/60. It's a pregnant lady. We advise an HFA and an MRI. And here's a meningioma. There's the 26-year-old male this time. Left blurring of vision 3 to 4 weeks associated with headache. 3 to 4 weeks associated with headache. This is the vision. Now, here, if not anywhere, the importance of history. Everything is normal, ESR is normal, everything is normal, and ma'am has already shown such cases. And look at the disc, but it's unilateral. And ma'am had classically said that these will appear bilateral because the history is, and this is elevated. You can see only on one side. Ayurvedic treatment. He had to stop Ayurvedic treatment. We gave him, it didn't have a centrocecal classical scotoma, but yeah, blind spot was enlarged. So we gave him 4 doses of IV methylprednisolone, resolved to 6/6. This is a post-treatment picture. It's still on the resolving stage. This is something, last case, had a history 1.5 years ago of vitrectomy, membrane peeling, endolaser, and cryotherapy. 6/60 in the left eye. This was the past picture for which vitrectomy was done. This was not done at our place. This is how she presented to us. Disc edema and diagnosis of hemangioblastoma. This is a peripheral cryotherapy that was done and presenting as disc edema. So here again, this is the classical picture. And one, as I go, one for you. What do you think is this? Madam has already given huge clues. Neuroretinitis, secondary to something. Yeah, so here again, if I can stress upon the fact that the history is very important, not, and this is the red-free images, cotton wool spots, the OCT, and finally it was turned out to be post-typhoid. So as we saw 2 cases belonging to this part of the axon, 2 to the papilla, and 4 to the remaining part. And thank you from me.
Virendra Sachdeva, not here. We will go to the next speaker, and if he can come, he can join the thing later. Dr. Muralidhar Rajam, yes.
He is not come for the conference. Virendra Muralidhar इसमें है visual pathway class. Thanks for including me here. So I'll be talking on working up the visual pathway. Part of it has already been covered by the speakers. There is bound to be some overlap in the talks. So this is the visual pathway. All of you are aware of the field effects that can be produced. So can be found in almost all visual field textbooks. So it's important that you are aware of this. So before I start my main presentation, I would like to take you through all these cases. Because many of them were sent to me for neurophthal opinion. Many of them were sent to me for neurophthal opinion. This one presented with an acute visual loss. If you notice, this patient has pseudoexfoliation. So actually there is not a neurophthal cause to it. The optometrist has written dull glow, and the PG has seen the fundus and referred it to me, saying there is no RAPD, or she's not able to assess the RAPD because the pupil itself is so small. So remember, we are ophthalmologists first and then neuro-ophthalmologists next. If you make a close slit here, this patient is aphakic. So that is because this patient has pseudoexfoliation and the bag IOL complex has dislocated into the vitreous. So I called the optometrist again, did the aphakic refraction. Patient has a vision of 6/6, referred to vitreoretina for further management. And this patient was referred as disc pallor. Note the cupping here, and the nerve fiber bundle defect is seen here, nerve fiber bundle defect. So this patient has a glaucomatous optic neuropathy. To be referred to glaucoma. And this patient was referred as disc edema. This patient had already spent quite a lot of time, had come around lunchtime, and had already spent around 3 to 4 hours waiting for neurophthal opinion. So I called the PG and requested her to take the blood pressure. The blood pressure was this much. So malignant hypertension, we have no business with these patients here in an ophthalmology setup. These patients have to be urgently referred to the intensivist or the cardiologist for further management. You keep them in your ophthal clinic, you are asking for trouble, because they can go in for decompensation. Even young patients are developing this. Very, very young patients are developing high blood pressure. So any patient with disc edema, unilateral, bilateral, please remember to record the blood pressure once. So this patient was again referred as optic atrophy. So if you notice, in addition to optic atrophy, this patient has generalized arteriolar attenuation, and also had a history of, I just asked one history, do you have night blindness? So the patient said yes, and this patient has a classic retinitis pigmentosa. And this patient, if you notice here, so this patient was referred with gradual, painless, progressive vision loss, referred because nobody else could pick a cause to it. So I just asked about history of flashes. So I asked about history of flashes, and the patient said, yes, I have history of flashes. So I referred the patient, courtesy Dr. Paraksha, and this patient has a flat ERG. So essentially had carcinoma-associated retinopathy. So these are history points that we need to take. Remember that we are ophthalmologists first. Again, this patient was also referred because of unexplained vision loss. So if you ask the patient to look down, this is Munson sign. So we have traditionally been taught for our exams that if you cannot find anything, remember keratoconus, call the optometrist and speak. Of course, scissoring was mentioned and was again missed, and this thing was referred to neuro-ophthalmology. So coming to the main presentation. So this patient gave a history, 2 slides back to back. So history of headache, and the visual functions were normal. I should have included the visual fields here. I forgot to include. So you have disc edema, headache. The blood pressure was normal for all these patients. I have already mentioned the blood pressure here. So it is mandatory in our clinic that if you have a disc edema, further workup goes only after measuring the blood pressure. So you have this disc edema with nerve fiber layer fluid. And so the investigation that you need to get done here is MRI with contrast and MRV. It is not CT scan, it is not MRI alone, it has to be MRI with contrast and MRV. The reason I'll mention in the slide, and remember this sign on OCT, there is an inward pointing of the Brooks membrane. In the other condition, if it's a primary pathology of the optic disc, it will be outward pointing. So the Brooks membrane is pointing inward, suggestive of papilledema. Okay, and both cases the optic nerve functions are essentially normal. This showing some constriction, and sorry, the slide is flipped. If you see here, there's a widening of the perioptic. This is a T2 weighted image. See, the vitreous is white here. There is a widening of the perioptic space. There's a partially empty cella, and most importantly, there is a flattening of the globe, better seen in this image in a higher magnification. And if you see here, so if you see here, there is a flattening of the sclera, and there is also a bulge here. So these are all signs of a raised intracranial tension. So again, why the intracranial tension is raised? You would need an MRI with contrast. Again, I repeat here, it's an MRI with contrast and MR venography. This was an unfortunate incident that happened. Patient was referred as MRI with the above clinical signs, and was treated with Diamox. The papilledema was not resolving. So the neurologist at this point of time decided to get an MRV done. This patient has a superior sagittal sinus thrombosis. So it is not worth missing this. These patients can develop hemorrhagic infarcts at any point of time. So always get an MRI with MRV done. So again, history is the key. So the patient again referred with optic atrophy, had a history of craniopharyngioma excision. So our role here actually had been sent by the neurosurgeon. Only if you ask, they tell all this, that the neurosurgeon had requested an ophthal opinion. No letter was given. So patient was sent to the neurophthal clinic. Your role lies in monitoring by visual acuity, by color vision, and any patient 8 years or above can have an automated perimetry also done. 8 years and above, you have a normative database, you can get automated perimetry now. So here again, this patient had lost vision. So it is important here, this is a traumatic optic neuropathy, very evident from the history. What is important here is you need to specifically ask them, was the vision loss noted immediately after the injury, or was it a gradual, painless, progressive vision loss? So here we had the records that documented that the vision was immediately lost following the injury. So this again, a very, very important thing. You hear a lot of patients losing vision after illicit liquor consumption. So this patient also had a history of methanol consumption, possible methanol toxicity, because many of his colleagues also had consumed, colleagues of friends had consumed liquor, and they also lost sudden vision. So management, you could give them a IV folinic acid, but that's about it. Management has to be, because they have metabolic acidosis, and they can have a lot of systemic complications. They can also have renal failure. So they have to undergo hemodialysis and hemoperfusion along with IV folinic acid and IV ethanol. Paradoxically, ethanol is given for methanol toxicity to reduce the metabolism. So that has to be given, done by an intensivist only. And because of some delay in treatment, this patient only managed to get counting finger 50 centimeter vision after so many days. So again, in methanol toxicity, IV methylprednisolone has absolutely no role. So now this patient came with a sudden vision loss. So sudden vision loss and typical altitudinal field defect. So here there is some there are some issues here. So some issues because because two speakers have not come, so I'll just take a little extra time if that is okay. Yes. So typically altitudinal vision loss. Here I want to point out that MOG optic neuropathy, MOG optic neuritis can very much mimic a non-arthritic ischemic optic neuropathy. So if the patient presents to you after 2 weeks, then you can get the OCT angio done, which can help you avoid an MRI in these patients. So if you notice here, the OCT angio is showing a segmental loss of disc capillaries. So you have an inferior loss and corresponding superior altitudinal field effect. So we managed to avoid an MRI in these patients. If the patient presents after 2 weeks, if within 2 weeks you get an OCT angio done, you will not get any information because of the disc edema. OCT angio may fail to show this loss of capillaries. So again, this is very, very important, already pointed out by speakers, by madam before me, that you need to, in any patient with a bilateral optic neuropathy, it can be asymmetric also, you need to take a history of ATT, specifically ask them. So because of this new RNTCP, earlier they used to be given HRZE for 2 months. INH, rifampicin, pyrazinamide, and ethambutol for 2 months. Now it is extended for 6 months, sometimes even 9 months they are on ethambutol. And this weight-based dosing regime that has been introduced by RNTCP has resulted in some patients getting extra ethambutol. So unless you stop it on time, so this patient is going to have a permanent and severe vision loss. So notice this. So this patient was on 8 months for pulmonary tuberculosis and was on ethambutol 1,200 gram, which was because he was taking it both from his treating hospital as well as from RNTCP. And after stopping ethambutol, he still was left with optic atrophy and a field defect, but his vision came back from here 618, 660 to 69 in both eyes. So this is very, very important. History is extremely important. Now, this is where I have burnt my fingers many times in the past. So I want to share this case with you. So pain during eye movement with some vision disturbance. So the vision is normal, color vision is normal, visual fields are also normal. But because I have burnt my fingers, optic neuritis can worsen in the first 2 weeks. So in these patients, please follow them up closely, especially if they are very particular. The pain is there during eye movement. Follow them up very closely. And this patient actually came back. MRI was normal, and he was a MOG positive optic neuritis. So if you fail to follow them up, fail to institute steroids on time, the vision loss is going to be permanent in MOG. MOG may be slightly less dangerous, but if you do not give steroids, it is going to devastate the patient. So now this patient is very instructive because we very often fail to take this history. So I had a simultaneous vision loss. Okay, it is important to know whether it's a sequential, as in Leber's optic neuropathy, or it's a Leber's hereditary optic neuropathy. It was a simultaneous vision loss and had chronic diarrhea. So we suspected that this patient had got B12 folate done, but that was way back in 2021, and this patient presented in 2022. So I had chronic diarrhea and had this vision, which was sitting at 612, 636 with zero color vision and with visual fields that was severely depressed and with an extensive ganglion cell loss. So if you see, it's a bilateral optic neuropathy and MRI was normal. Any bilateral optic neuropathy, however classic the presentation may be, please have an MRI with contrast done before you venture out into all these kind of diagnoses. So the hemoglobin was normal, but if you notice here, there could be a clue. We always get, hemogram MCV done. So MCV is a little more. Okay, it could be an early megaloblastic anemia. And if you see here, the B12 levels are low. So in combined B12 and folate deficiency, it's always important to either correct them together or to correct the B12 deficiency first. If you correct the folate deficiency first, hematopoiesis will kick in and the patient will go in for demyelination of the cord called the subacute combined degeneration of the cord, because B12 is given by injection. So patient may take some time taking the injection. If you give the folate tablets, patient will consume that first. And because the oral absorption is unpredictable for B12, better to give the injection first and then give the folate. So always look for orbital signs. So this patient presented with gradual painless progressive vision loss. If you see on Nafziger's sign, this eye appears to protrude a little bit. The visual fields are severely depressed. So we got an MRI done and true enough had a large schwannoma on the right side, had a large schwannoma on the right side. So important to comprehensively look at these patients. So the importance of diagnosing these three, as has been pointed out, is because the treatment varies so much, already been covered by my speaker, but it is important to know that you really need to distinguish between these entities. So remember COVID always. So this patient had a history of COVID, was poorly controlled diabetic, and was referred for pulse steroids. But if you get the MRI and you see here, the patient has an invasive fungal sinusitis. Okay, so refer to the ENT surgeon, and patient did get back very good vision. So again, this patient presented with this history of sudden painless loss of vision over a week's time. The fields could not be done here, but this field is respecting the vertical midline. Okay, this field is respecting the vertical midline. So this was a large cellular mass. So even if you have a temporal field defect in one eye, take it very significantly. Get an imaging done at the earliest. So this was a large cellular mass. If you notice, the temporal hemianopia is complete only on one side. On this side, it's quite incomplete. But this patient had a very large cellular mass. So and the seesaw nystagmus. Seesaw nystagmus is also typical of these cellular lesions. You can make the diagnosis at the bedside. So this is a pie. I'll rush through my remaining slides. This is a pie on the sky. You consider a temporal lobe lesion. So post-traumatic, this patient has a temporal contusion here. And this is a pie on the floor defect. So again, learn to recognize the 120-point screening, which can be done if the patient has come dilated to you, as often happens in a busy clinic. So pie on the floor and has right parieto-occipital infarct. So this is a very strange thing that happened. Patient complained of left side field defect. If you notice, half sector in each eye is involved. So it's a sector anopia caused by a LGB infarct. Very rare condition that happens. This is the LGB infarct, and has to be referred to a neurologist. So if you see, this patient has extensive field defect. This field defect appears to respect the vertical meridian, and so does this. So this patient has a bilateral homonymous hemianopia. I learned this term from Dr. Andrew Lee, and has bilateral acute infarct in the occipital lobe on both sides. So bilateral usually spares the macula. And this history of malignancy is very important. So this patient came with counting fingers vision, and incidentally, when she walked, when I got up from my chair, she greeted me, and when I put my this thing on the slit lamp, she also said where she has to put. So everybody was thinking it is kind of functional vision loss. Please notice, these patients with occipital lesions can have statokinetic dissociation. They can perceive moving targets. So when I got up, she wished me. So that led me also to think fundus was normal, but she had a history of malignancy. So we decided to get her imaged, and she has this chemotherapy was completed 6 years back. And if you notice here, there are multiple metastases in the occipital lobe. And what would have happened if we had just dismissed her as malingering? So multiple lesions in the occipital lobe. So remember the statokinetic dissociation. That is my last slide. And thanks to all those in my clinic at Eye Foundation who had referred it.
Thank you, sir. Now, last speaker, Dr. Varda Gokhale.
I have to play from here. Good evening, all. Thank you, AIOC and sir, for giving me this opportunity to present in front of you. So, I'm going to the basic. I'm going to talk about pupil evaluation. Why it is important? Because pupillary function is the most important clinical sign in patients with vision loss and neurological disease. There can be afferent pupillary defect, which can point towards any lesion in retina, optic nerve, chiasma, or tract, or there can be efferent pupillary defect, which can point towards a serious neurological condition such as aneurysm or tumor. So this is a normal pupil. A normal pupil is a single aperture present in the center of the iris, slightly nasal. It controls the retinal illumination, it reduces the optical aberration, and it also helps in depth of focus during accommodation. Before examination of the pupil, the prerequisites are room illumination, permits easy control to the background illumination, source of light. As you know, indirect ophthalmoscope is the best source of light to elicit RAPD or pupil reactions, pupillary gauge to measure the size, slit lamp, neutral density filters, and in special situations, some pharmacological drugs. Also, we need a little time of the clinician and sound understanding of pupillary functions. Pupil evaluation can be done by number, location, size, shape, color, reflexes, and pharmacology. So, pupil can be tested by direct light reflex, consensual reflex, swinging flashlight test, and near reflex. Pupillary disorders mainly classified into three types, like abnormally shaped pupil, abnormal pupillary reaction, and unequal pupil size. So coming to the size and shape, so that is there can be a polychoria which can be true with an extra sphincter and can be pseudo. The size can be congenital, there can be congenital miosis or congenital mydriasis. Basically, the size of the pupil is influenced by ambient light, state of the retinal adaptation, level of arousal, and patient's age. Small pupil points towards pontine hemorrhages, narcotic intoxication, pilocarpine, whereas large parasympathetic blockage use of stimulants or state of high anxiety. Shape, there can be congenital aniridia, that is PAX6 gene involvement, also associated with WAGR syndrome. Shape can be abnormal in iris coloboma, chorectopia, ectopia lentis et pupillae. Abnormal can be because of sphincter tear or iridodialysis in blunt trauma, or there can be posterior synechia. We check the reactions, and most commonly, what we do is swinging flashlight test to detect afferent pupillary defect. So here the pearls are the patient should look at the distant target. Here I am testing in a children, which is a little difficult. Uh, RAPD can be measured with a neutral density filter. You have to perform swinging light test in both eyes till it is equal. Abnormal reaction can be seen in cluster headache, migraine, astrocytoma, Horner syndrome, and after carotid puncture, and during or after seizure activity. Coming to abnormal shape, size of the pupil, we call anisocoria. That is difference in two pupil by 2 millimeters, which is common and normal in 10 to 25% of the population. Here, the key is you should always check a dilatation lag. So, in Horner syndrome, there are weak dilator muscles and we get a dilatation lag. So, if there is dilatation lag, we don't need anything else to diagnose Horner's pupil. So, here is one case of 8-month-old baby came to my OPD with a mild ptosis in the left eye. LPS action was good. On keen observation, there was an isocoria. There was difference of 2 millimeters in both the pupils. There was dilatation lag. Pupil was reacting to light, and on history, there was decreased sweating on left side of the face. So the differentials were third nerve palsy, ocular myasthenia, mechanical ptosis, or sympathetic palsy, that is Horner's syndrome. So what we did was MRI chest and head neck, and we got an Pankos tumor, that is a mass on the apical portion of the left side of the lung. So typical features of Horner's are mild ptosis, upside down ptosis, meiosis, anisocoria, dilatation lag, which is most common. Everyone should not go for tests, pharmacological test, but look for dilatation lag. Apparent inophthalmos, accommodation can be paresis or increased amplitude both. Hemifacial anhidrosis, and you can see heterochromia iridis, most commonly seen, and ipsilateral straightening of the hair. It can be a central Horner pre and post ganglionic. Now we need pharmacological testing to differentiate between the two by hydroxyamphetamine tests. Cocaine is not available, so we usually don't perform it. So this is a chart how we differentiate between pre and post ganglionic testing of Horner syndrome. Apraclonidine is also used. This is also not available in India so commonly, but this can also, if you put in a Horner size, that is small pupil eye, there is a denervation supersensitivity of the alpha receptors, and we get a reverse Horner's. So this is a busy chart, but everyone should know that anisocoria should be tested in a dark room and a bright room. If anisocoria is greater in dark, do apraclonidine test. If positive, it is Horner's. If not, it is usually physiological. If anisocoria more in bright light, then more common is third nerve palsy with abnormal muscles. If the muscle movements are normal, then think about other things like Adie's pupil or angle closure glaucoma, where there is a vertically oval fixed mid dilated pupil. So Horner's being sympathetic palsy. Now coming to parasympathetic palsies, we have Adie's third nerve and pharmacological pupil. In Adie's, we get vermiform movements of the eyes. Okay, there is a lesion at the ciliary ganglion, and there is aberrant regeneration of the fibers originally destined to ciliary body, now innervating the sphincter. So there is abnormal reaction. You can check on the slit lamp for the vermiform movements at the pupillary margin. Most commonly, what we observe is accommodative paresis. Patient complains of difficulty in reading. If it is also associated with deep tendon, absence of deep tendon reflexes, it is called home Adie's pupil. Third nerve palsy, everyone knows if it is involving pupillary fibers, that there is anisocoria, then we should always think about something serious, that is aneurysm, tumor, or uncal herniation. Wernicke's hemianotic pupil is mainly seen in lesions in the optic tract, that when we shine a light, When the light reflex is absent, when light is thrown on non-seeing part of the retina, but reacts when the light falls on the seeing part of the retina. There is another condition called light near dissociation. I'll cover just two. That is Perinaud syndrome, already covered by Sir. That is dorsal midline syndrome. Most commonly, there is accommodation reserved and light reflex is gone. The causes can be pineal gland tumor, hydrocephalus, and midbrain hemorrhages. There is defective light reaction of the pupil, near reflex is preserved, vertical gaze abnormality, downbeating nystagmus, bilateral superior oblique palsies. I'll skip the video for now. And the last is the Argyll-Robertson pupil. The difference between the two is in Argyll-Robertson, the pupils are always small. You get a small pupil, very rarely seen in common practice because the reason is syphilis, which is now rarely seen. But we need to check for near reflex also whenever we are evaluating pupils. So my take home message is testing the pupil's reaction to photic and accommodative stimuli is a key part of any ophthalmic examination. Relevant history taking and keen observation for subtle clinical signs can detect life-threatening conditions. Thank you. I acknowledge LVPI and Dr. Niranjan Pere for the videos. If the time permits, I'll show that video.
Maybe two, so we can have a photograph. Any questions from the audience?